fabulous introduction. We have two of our future investigators and teachers and practitioners here. Now we're gonna move onward to some, what do I call us? We're mid-career. Is that a fair? Late career, fair enough. We're going to move on to a couple of guys you probably know, and I've known well for a long time, who are mid-career investigators. We're going to be doing a fun debate for the next hour, actually. And then we're going to have a break, by the way. So there's going to be a break coming after this, so sit tight for this, and then you have some time to hang out in the exhibits. And by the way, there's posters, and we're giving away money, and there's all sorts of fun stuff to do out there. And we'll feed you. It's exciting. But before that, we're going to have these two guys battle it out for an hour about colon cancer, which is where we're going to stay. I will tell you, we did this format last year. We did this debate about colon cancer stuff, and we had Uri and Samir Gupta. And Uri apparently beat him up badly enough that we had to get a new fresh meat for him. So we brought in TR as the new victim of the Uri WWE pummeling. These two guys are buddies. They're going to talk about sort of controversies, if you will, and issues in colon cancer screening. I suspect they both agree in the middle of most of the points they're going to take, but we're going to ask them to kind of take competing viewpoints and help us work out the nuances of this. They really don't need introductions, but I'll briefly introduce. On my left is TR Levin, who I've known for probably 20 plus years now. TR is the lead for colon cancer screening at Kaiser in Northern California. He's part of the Kaiser Division of Research. He's chief of Kaiser's Northern California Diablo area, or some circle that they drew around and tell TR to take care of. He was on the Multi-Society Task Force on Colorectal Cancer Screening. He's been replaced, in fact, by the woman you just heard speak. So he's emeritus, we can call him. He's actually, I think, the only guy I know personally who's literally had 2 articles on the cover of New England Journal in one issue on 2 different topics, actually, which is, this was not like something they divided into 2 papers on 2 different things. That was 7 years ago, and I'm not sure what's going on since, but TR is really a world leader in colon cancer interventions and screening. Next to him on my right is someone you all know as well, which is Uri Ladabaum, who I've also known for probably 20 years. Uri was at UCSF when I was hanging there for a while, and he since went down the road to Stanford, where he is the clinical chief, actually, of their division and the director of their GI cancer prevention program. His research is exactly the same, is basically risk stratification and cost effectiveness and outcomes for colon cancer screening. And it's really exciting to have these two kind of go at it for the next hour. So thank you both for doing this.
Yeah.
While they're setting up their computers, I'll just throw out parenthetically that on your little app thing that you can scan and get to, we have faculty bios and stuff, and I just wanted to highlight that Dr. Levin, since we took that picture, I encourage you to go look at it. Since we took that, TR's apparently had a little bit of work done, maybe some Botox, some sculpting or something. In fact, the picture is not Dr. Levin. It's actually Dr. Anthony Lembo, but apparently you're doing an impersonation today of Dr. Lembo.
Thanks so much, Neil. Thanks to everyone who organized this meeting. It is fantastic to be live, and it's an honor to be asked to do this. TR asked me to tell you how we arrived at these topics. We discussed them amongst ourselves, among the organizers. We tried to pick things that were controversial and that would stimulate debate. And then how did we take sides? It was a flip of a coin, and that results in some very interesting things that you'll see down the road. So first topic. Given the new screening guidelines, GIs should actively work to get persons 45 to 49 screened. And of course, the answer is yes. And I'm going to try to convince you of that with 5 points. So why yes? You can take the easy way out. There was a time when we could sit here and hem and haw and say, oh, the American Cancer Society is recommending this, it's a qualified recommendation, it's controversial, are others going to follow? Well, yes, others have followed. ACG clinical guidelines now endorse screening 45 to 49. It's again conditional. At the time that this came out, very low quality evidence, but that was number 2 if you're keeping score of the thinkers who say let's do this. And then of course it's the USPSTF, the grade is B. But that's primarily because of extrapolation from data in older age groups. But the notion is things are changing, epidemiology has changed, which we've talked about, and so we should do this. So should we do this? Of course, the guidelines now, 3, say we should do this. But that's a bit of a cop-out. So the question is, why have the guidelines changed? What is the rationale? And I think the most compelling point is that there is increasing risk, what has been described as the birth cohort effect, meaning people who have been born in cohorts that are closer to now in time period, younger people, have higher colorectal cancer risk at a given age than people did in the past. And there are various ways to visualize this. This is one of the initial papers that really started people thinking about this strongly by Siegel and colleagues. And what you see here is that compared to the risks that you saw for people who were 50 years old in the year 2000, that's that dotted bar that I'm showing there, there has been increasing risk of both colon and rectal cancer in cohorts that have been born closer and closer to us today. So what I've drawn here are 45 to 49-year-olds today in 2021, and you see that the incidence rate ratios for rectal and colon cancer are 2 to 4-fold compared to people in the 50s. People who are 50 years old in 2000. So higher risk than in the past. This shows it by 5 age blocks. So what you're seeing is across the bottom, the birth cohorts, and you see that the rates per 100,000 people have gone up for colon in the left side, up for rectum in the right side for young people. And you contrast that with how it looks for older people, where it's coming down. Now, people debate how much we can take credit for screening, taking care or accounting for what's happening in older people, but probably screening's a big part of it. What epidemiological things could be going on that impact the older and younger so dramatically differently? Well, there may be some, but the notion is that there's something going on that's increasing colon cancer in the population overall, particularly in young people. We are fighting against that with other things in older people, but be that as it may, things are changing. Now, I want you to focus on these two, the orange and the pink, the 50 to 54-year-olds compared to the 45 to 49-year-olds, especially the more recent trend. And you'll see that the pinks are going up and getting close to the orange. So some of you may remember this show, Orange is the New Black. Well, here, pink is the new orange. Basically, people in their late 40s are looking like people in their early 50s used to before. And so if we say, let's screen people in the early 50s, and we've done that for a long time, now looks like the people in the pink, people in late 40s, are the same in their risk or approaching it. Number 3, we have emerging evidence that there is potentially benefit proven in this age group. It's no longer just expected benefit. So when the American Cancer Society came out, they basically said, we think that what we've observed in older groups, because none of the previous studies were focused on or powered to look at people screened in the late 40s, we think that what happened in older people will happen in younger people, so we extrapolate, let's do it. There's actually emerging evidence that there is potentially this protective effect. And by the way, I don't think we're likely to have randomized trials in this age group compared to no screening. So we're going to be stuck probably with observational evidence. So this is a study that our group published recently looking at patients who either had exposure to colonoscopy or did not have exposure to colonoscopy at specific ages, and we looked at people in the late 40s, and then also for comparison at people in the early 50s in Florida over a long period of time. And what you'll notice in the solid bar are the people exposed to colonoscopy. In the broken line are the people not exposed to colonoscopy. And what we're showing here are the proportion free of colorectal cancer. So you want to be the higher line. You are less likely to have colorectal cancer. And over time, these two diverge. So that exposure to colonoscopy in the late 40s was associated with a decreased risk of developing colorectal cancer later. It's what you would expect, but we had not had data on this group specifically. If you look at this as an overall result, we had many patients, hundreds of thousands, and actually in the non-colonoscopy group, millions. And the bars for the 45 to 49s are on the left, for the 50 to 54s for comparison and on the right. The people in green are those who had colonoscopy. In red are those who didn't. And when you look at the adjusted hazards ratios for people in the 40s, it's 0.5 for having had colonoscopy versus not. In the people in the 50s, it's 0.32. I would caution you not to compare these two and say, oh, colonoscopy has a stronger association in older people and younger people. Realize that this was not a screening period for people in the late 40s. So people are getting colonoscopy for other reasons, maybe symptoms, higher risk, and so on. So I would not conclude from this that there's a differential effect. The most important message is emerging evidence that colonoscopy in the late 40s is associated with decreased subsequent risk. So you marry that with the guidelines that talked about expected benefit. Now we have a stronger case for expected benefit. Number 4. I think we are unlikely to disadvantage others. In the US, we can probably do it. What do I mean? We may potentially face trade-offs, but I don't think they are real in the US. And one way to think about it is that there's a lot of lower value care. So if in our own practices we just said, you know what, I'm going to be more careful about repeat endoscopies on persistently symptomatic people, repeat CT scans, right there are the resources to expand screening. And I'll flesh this out a little bit. Now, when we looked formally at the potential effectiveness and cost effectiveness of this strategy with modeling, we put together this visual abstract. What the box is showing is the number of incremental colonoscopies that you would need in order to move screening from starting at 50 to 45. That's the first column. And you'll see that if you wanted to screen an additional 1,000 people earlier, you have to do almost 800 additional colonoscopies. You would prevent about 4 colorectal cancers and 2 deaths. You gain some life years. And the money it costs you is acceptable by all cost effectiveness standards. So the first column will tell you this is cost effective. But what we try to show is that if you only had those colonoscopies, you could do column 2 or column 3, which is apply those to people who are 55 and unscreened, people who are 65 and unscreened. And there you would have enough colonoscopies to manage 200 to 300 people who are older, who don't have screening, for their entire lifetime, and you save a lot more colorectal, you prevent a lot more cancers, a lot more deaths, you gain more life years, and here it's actually cost saving. So if you have a fixed allotment of colonoscopies, you can make the compelling case, don't spend those in younger people, get the older people unscreened. Now, that is a lot harder said than done. We've been trying to do it for a long time. If it were easy, we might have solved it already. So I want you to think about this in a different way here. Without screening, the number of colorectal cancers and deaths are shown as predicted here. You do about 330 colonoscopies over a lifetime. You don't do any FIT tests. If we start at 50, I showed you the numbers before. You decrease the colorectal cancers and deaths substantially. Now you're doing a lot more colonoscopies, 4,400. If you start with colonoscopy at 45, these are the numbers that you saw there. You save about 4 colorectal cancers in incidence, a couple of deaths prevented. You're doing a fraction more colonoscopies. And if you're worried about our capacity to do that, then there are other possibilities. You could start, even if you're an enthusiast for colonoscopy, you could say, let me do FIT in the late 40s, then switch to colo. You see the outcomes are similar. You have similar number of colonoscopies as you're doing already in a colonoscopy at 50 strategy. Of course, you have to do a bunch of FIT tests. So it's not all about colonoscopy. This is about screening in general. Another important point, we are moving towards less surveillance. We have shown that there are a lot of people who previously were getting surveillance that probably don't benefit from close surveillance. The high-risk subgroup is getting smaller and smaller. So if we do less surveillance, right there are more resources for screening. And I think that is very much a worthwhile shift. Number 5, let me read you a quote. "It matters how old you are when you die, because your role in society differs," said Dr. Mary Bassett, director of the Francois Xavier Banu Center for Health and Human Rights at Harvard's T.H. Chan School of Public Health. What was this in reference to, and what's the source? Well, this is actually a pretty recent New York Times article, and the headline here is "How the Virus Unraveled Hispanic American Families, Deaths in Santa Clara County, close to where many of us, or exactly where many of us live and work. These deaths highlight a terrible disparity of the pandemic. COVID-19 killed many Hispanic Americans at younger ages." So we often don't talk about the age, but this goes on as follows from Dr. Bassett. When you die young, you may be a critical breadwinner for your family. You may have dependent children. And we know that losing a parent is not good for children, and it has an impact on their future development and psychological well-being. So cancer death when young is particularly devastating. Now, I say this with caution. Why? Well, I could open myself to criticism of being ageist. Am I valuing younger people over older people? The quotes that I showed you, am I valuing parents more than non-parents? Because we talked about the impact on children. About income, am I valuing employed people more than unemployed people? It gets very, very tricky. But I would ask you to look inside yourself and say, if you have an allotment of screening resources for yourself, would you shift your own lifetime allotment of screening to a younger age? If you get X number of colonoscopies, do you want your first one at 45 or at 50? Or if you're older than that already, for your loved ones in the new era? Is there a special dimension based on age? And this relates to disparities. And we could have had no better context for this than Fola's talk. What should we do? So think about it this way. This article goes on to say the virus more often killed white Americans who were older. Their deaths were no less tragic. So we're not saying it's less tragic, but they did not lead to the unraveling of income streams and support networks that was experienced in Hispanic American communities. And this is because death rates were younger. These families experienced a very different pandemic. So I'm borrowing from something that we've all lived. Most of us, I think, have been lucky that we have not had this in our families. Those of us who may have suffered like this, it is awful. But here you have the effect of age. So screen 45 to 49, absolutely yes. Why? It's endorsed by guidelines. The guidelines consider epidemiology and the expected benefit. We now have novel evidence that the expected benefit may actually be actual benefit. It is unlikely to disadvantage others if we do it right in the US. And diseasing young deserves special focus, but with an asterisk, we have to be careful not to disadvantage other groups.
Start the. Okay. There we go. So I'd like to reclaim some of my time. I think we allotted 5 minutes per talk, and and I also understand why Samir felt kind of beaten down last time. I want to start off and just address one point that Uri just raised, which it seems like he's coming from a perspective that we actually work in a U.S. healthcare system where we can shift between different modalities. I think many of us, even in a system where I practice, there's a lot of just episodic care, opportunistic care that occurs, and I think Fola's talk really set us up really well for this. I think the people who are going to be coming in at 45 are going to be the white, wealthy, self-actualized patients. We have patients that Fola was referring to who aren't even coming in for their care at 50 or 60 when we really can make a big difference, and it's going to take a special shift of resources, but that's just kind of an overall editorial comment. I'll say that with due respect to the paper that Uri just showed us with the effective colonoscopy, I'll say the evidence base for this consists entirely of modeling results, and this is actually, for the U.S. Preventive Services Task Force to go there with the 45 to 49 really represents a whole paradigm shift in what is the evidence base that we expect for a screening intervention. When you take healthy people and you're disrupting their lives, potentially exposing them to a intervention that could injure them 1 out of 1,000 or 1 out of 3,000 times. And so I think we need a higher bar of standard of evidence. There's no empiric data. I think Uri's probably right that we're not going to get clinical trials, and now that this has been approved, I don't think we're going to get a clinical trial because of that. CRC incidence is increasing in younger people. I think there's no doubt about that, but it's still 2 to 4 times less common than in people who are 50 or who are over 60. And we've got Uri's data that basically showed us it is more cost effective to screen older people.
And then we should really be focusing our resources on those people who are 50 and over. And we don't really know whether the natural history of colon cancer in the young is the same as that in the old, and how effective. I think there's probably reasonable to assume that it'll be somewhat effective, but we don't know. We don't really know the magnitude of the effectiveness in the younger people. Now, having given you the rationale, I'll also show you that we also don't know the uptake in the yield of screening in this age group. We don't know how that's going to perform, and whether we're going to be exacerbating disparities by just the people who are wealthy and have the free time to spend the extra time, traveling to UCLA to get their colonoscopy versus needing to take 2 buses or unable to leave their job. So Uri showed you these slides, and it's really, it goes without saying that we're definitely seeing a birth cohort effect, and we're definitely seeing an increase, whether this is from sugar, potentially sweetened beverages, there was an article just recently on that one, or whether it's antibiotic exposure. I have a colleague, an epidemiologist at the Kaiser Division of Research, who thinks it's because the younger people have all been carrying their cell phones in their pockets, and that's why rectal cancer is more common. He does a lot of work with radiation exposure, and so definitely had some early signal from some very preliminary data that gave us all a lot of pause. But I think this is really, this was Uri's paper, so we'll just kind of say that you can see the increase in incidence or the prevalence of disease, or the incidence rate and the incidence ratio as you look at the older versus the younger. And it's really 2 to 4-fold higher in the older people, and that's where we're going to make the biggest impact. And definitely, the USPSTF was all based on models, and you can see for the different modalities of screening, whether you're looking at benefit in terms of life years gained or other benefits, you can see that there's a small increment in value of extra life years gained or CRC deaths averted by starting at 45 compared to starting at 50. But a big, especially if you're talking about doing colonoscopy every 10 years, a big impact on the number of colonoscopies someone will have in their lifetime. And I practice in a setting where we do a lot of fit screening, and that'll become interesting a little later in this talk. But most people, and I think for most of the people in private practice or academic practice who are in this room, you guys are going to be doing colonoscopies on these patients, and we're going to be doing a lot more colonoscopies on these folks. And so I think that the payoff in terms of colonoscopies versus life years gained, I think, is relatively small. This is Uri's model, and he definitely showed a bigger impact in terms of cost effectiveness by starting at 50 or focusing on the older ages. And I'll even just read his conclusions. In his Markov model analysis, they found that starting CRC screening at age 45 years was likely to be cost effective. However, greater benefit at lower cost could be achieved by increasing participation rates for unscreened older and higher risk patients. And this was another paper. It's very easy. I could have just searched Uri in PubMed and kind of done my whole talk this way. But he definitely, they compared the potential unintended consequences of starting young. Obviously, diversion of resources to the lower risk population, increase in screening disparities, substantial cost, lost opportunity to study. We're not going to do a trial, especially now that the USPSTF has mandated insurance coverage, essentially for this as a preventive benefit. And we're not sure whether the actual benefits will fall short of the predictions. So what about the real-world evidence of whether this works or not? I think Uri gave us a little bit, but what's going to be the uptake of screening? How is that going to affect disparities? What's the yield going to be? What is the impact on CRC incidence? And what's the impact on CRC mortality? And I'll just answer this the way Michael Jordan did, and just with a shrug, because we just don't know. Yeah.
All right. Well, that's just. They got 3 of these to go back and forth on, so that's just brilliant here, using what'd you call it, the Ladabaum model, yes, using, I guess you lost the coin flip, Uri, apparently. All right, we're going to do questions. We have 3 of these, and we're going to do questions in between, so that was brilliant, and you covered both sides of that. Questions particularly about this subtopic, and my monitor is. Am I getting questions from the outside world? There we go. Thank you. Thank you, thank you. So I'm going to look for questions from here. Questions from there? I got nothing coming. No. Why not do FIT starting at 40, TR? I mean, you're going to get to that, I think. One of your next topics is going to dive more deeply into that. But one of the questions is, why not start FIT at 40? It's alliterative, right? FIT at 40, we can make T-shirts, we can have races and stuff, right?
No, I mean, I think we might potentially get there. I think for all the resource implications that we're talking about, many of us are, I mean, I don't think I'm surprising anyone to tell you that we accumulated quite a backlog of screening with the COVID pandemic that we had last year. And so we're really trying to catch up with, I think, and starting at 45 is just introduces 20% more people into the population who need to be screened. So, I mean, I think we may eventually get there, and I'm sure there's going to be some motivated patients who are going to request that, especially now. But I think, for all the resource implications that we talked about, I think, starting FIT at 45 is cost effective, potentially, if we can make it happen. But I think 40, we're pushing it. But, we talk about the high-profile cases of colon cancer that everyone knows about, Jay Monahan, Katie Couric's husband, Chadwick Boseman. None of those would have been helped by a screening program that started at 45. So I think we'll get there.
Now that we have the new guidelines in place for the younger age, what should the role of the gastroenterologist be in counseling primary care providers about the preferred screening methods for these younger patients? Are we pushing colonoscopy? Are we okay with FITs for young people? Often these decisions, I think, are being driven now in primary care. And what should our voice be in this discussion?
I think the first question is, do we want to be endorsing this? Despite some of the stuff that we wrote, yes, I think as long as we can, in all honesty, say we're not disadvantaging other people, I think it's appropriate to endorse it. As to modality, I don't think it matters. I think there are all kinds of issues here, choice, infrastructure, and so on. Just get it done. I forgot to say in the intro, we are blinded to each other's slides, okay, in case that wasn't clear. So we don't know what we're saying.
You didn't know a lot about model was going to be pulled out of his pocket.
I had the advantage of going second, so I could react to some of his slides.
Dr. May.
We have time for one more.
Yeah.
What is the obsession with 5-year intervals? 45, 50, 40, and can you just comment maybe for everyone here, like, why not 46 or 43? And has anyone looked at that cost, mortality benefit, and whether we should stop at, when everyone's saying now, should it be 40? But, I mean, are we looking at numbers in between? Thank you.
I think it's also we do things annually, and is there something magical about the Earth, going around the sun that changes things? But it was interesting. It's an interesting question because Jordan Carlitz had a paper last year or the year before where he showed a huge jump up from 49 to 50 in terms of cancer incidence because everyone was starting screening at 50. Suddenly we're finding all those cancers. So, and I think in reality, if you recommend starting at 45, what will happen is the 45-year-olds, at least initially, many of them will be just surprised. For example, with the FIT mailing program like we have, maybe they don't even respond the first year, but then it comes back the second year. So I think part of the argument is invite people for a couple of years till they kind of socialize to the decision. Then it might be 46 or 47 when they actually start doing the screening.
So Fallout, 2 thoughts. Some modeling groups have tried to look at these, let's say, odd years. And yeah, you can find those, but it just feels awkward. What's the obsession with 5? My guess is we have 5 fingers, honestly. Why do we have a decimal system? So I think 10 is ingrained in us, 5 is ingrained with us. We think that way, but there's nothing magical.
It's the Greek mathematicians that gave us a base 10 math system, right? Which is an arbitrary thing, but all right, that's great. There are a couple of questions here about blood tests and FIT tests and stuff, but I think you're going to talk more about non-invasive tests. So I'm going to leave those questions, and let's go on to your second of third, and then we'll come back to those questions. You going to alter who goes first?
Yuri's got the third time.
I got this one too. Okay. Can you guys hear me okay? Because I was too close last time. So GIs should actively promote non-invasive screening methods like FIT. Okay. Thank you.
Okay.
All right.
I'll lean in.
So the answer to this question is, of course, yes. Why? Well, Ryan was getting to this a little bit. I would tell you there's no proven best test, and we know that the USPSTF does not have a ranking system here. If you're going to screen, just screen. It doesn't matter with what, but do it well. Now, there's been a change in tone even by GI societies. So if you look at what the ACG said in 2008, this was, I think, diplomatically worded. The preferred screening recommendations are cancer prevention tests should be offered first, cancer detection test is second. Built into this is the fact that FIT is much more sensitive for cancer than for polyps. So what's the preferred cancer prevention test? One where you also remove polyps, of course, is colonoscopy. The cancer detection test should be offered to patients who decline colonoscopy, or another prevention test. The preferred one's FIT. So colonoscopy is the best test. GIs are out there saying this. FIT is second. Now, it may seem that it's a subtle change in tone, but to me, it's not subtle at all. I think this has not gotten a lot of press, but it's remarkable how the latest guidelines basically abandon that. Colonoscopy is the best. They say we recommend colonoscopy and FIT as the primary modalities. No distinction. So I think even within GI, people are acknowledging it's not tenable to be pushing only colonoscopy. It's just not. So there is no proven best test. There's Equipoise even in research. There are ongoing randomized controlled trials. I think you know about the confirmed trial in the VA. All the sites in the US are shown there. The other famous trial going on in Spain, colonoscopy versus FIT. We have the initial studies of that, the initial report of that initial first round of testing from the Spanish cohort. But I will say this, there may not be a proven best test or strategy. Why do I say that? Because the effectiveness of screening is going to be a function of the efficacy, which is what these trials may show as part of the results, but also the participation. This is obvious, but it's worth saying. If people don't do it, you don't get the benefit. If people do it, you have the potential benefit. And this can differ widely depending on the system you're in and the support structure that you have. So it's not only the test, it's the program, it's whether people do it, it's how well you follow up. A FIT positive without a follow-up colonoscopy is tragic. I mean, that is an opportunity left hanging there. So it's not about the test. Number two, screening colonoscopy alone is unlikely to get us there. These are data that were published a while ago, but things haven't changed much. You can see that the fraction of the population that's up to date with screening goes up as a function of age. Most of it in the US is with colonoscopy, a little bit with FIT at the time that this was done. We are not reaching the aspirational goal of 80% or above, even in older people who've had a long time to get to this. And it's clear that what we're doing is not enough. Colonoscopy is not going to get us there. I think limited choice is good. Why do I say limited? If you show a patient the entire menu of the USPSTF options, I think they're overwhelmed. So that is not practical. But something that focuses on, do you want the most established non-invasive test like FIT, or do you want colonoscopy? I think people can handle that. This study comes from Penn. The numbers were small, so they did not show statistically significant differences for the group overall, but the differences in the female subgroup were significant. And what you see in the first set of bars is the group that was offered colonoscopy only. The next one is what they called sequential choice. Will you have a colonoscopy? If people don't do that, then, oh, okay, you didn't do your colo, will you do a FIT? And the last one is what they called active choice. Will you do a FIT or will you do a colonoscopy? And you see that the proportion screened for colorectal cancer overall in the dark bars goes up with choice. Again, not significant in this study. And the fraction of people who do colonoscopy goes down. So when people get choice, you get a lot of people doing FIT. So choice is good. Similar design, larger numbers, recent study from Poland. The top line is colonoscopy only, 18% of people do it. Colonoscopy, you don't do it, then you get an offer for FIT, 26% of people do it. And if you get the active choice, about 26% of people do it. So if you give people choice, you get more people covered. Number four, success, to actually have this succeed, requires some options. And look at this graph here. This is from Kaiser, Northern California. You'll see the inflection point there in around 2006, 2007, where the fraction of patients up with screening, which is the top line, goes up. They've reached the 80%, which is remarkable. Huge success story for population management. And a big part of this is the line with the X's, the fecal immunochemical test outreach program. Now, if you want to learn more about this, you can go to this YouTube video. You'll recognize this guy, first author on the paper.
I was much younger then.
And so there it is for you. Number 5, choice is the right thing for patients, and the future is coming no matter what. We have to do the right thing. Yes, there may be fewer screening colonoscopies, but this is not what should be driving the behavior of gastroenterologists. Colonoscopies that are fit positive results have more impact. We will do better. We should be happier to do these cases. And many countries do this, and health systems like Kaiser are leading with this. Our time and effort allocation may change, but there are other issues that we need to be dealing with. We've become, to a large extent, colonoscopists. That's fine for a certain point in history, but we need to evolve. And there are novel, non-invasive options. I think the promise of blood tests is huge. They're coming, so we're going to have to think beyond fit. So am I saying that screening colonoscopy is dead? No, I don't think so. I think it'll remain an option. It's the most sensitive one-time test. It's preventive. I think an exciting thing is if it's normal, there seems to be low risk for a long time. So is there something magical about 5 years follow-on? No. Is there something magical about 10? Probably not. Maybe you don't need a repeat colo in 10 years. It is a well-established test in the US, and we don't change very quickly, and I think some patients in the context of choice will prefer it. But we have to lead change in GI, not follow and say, oh my God, you're taking away our screening colos. So do we promote non-invasive methods? Absolutely. There's no proven best test. We have Equipoise. Colonoscopy alone is unlikely to get us to the screening targets. Limited choice is good. Success requires options, and go to the video by the guy next to me. And we need to do the right thing. The future is coming no matter what. But hold on.
What, do you want one more?
Yes.
Sorry. Did we lose your?
Can you guys give me back the? Okay. Yes. And now, thank you to Lady Luck, because these were coin flips. We get to see TR Levin arguing against himself.
Thank you. I told you this was going to be interesting. Let's see if we can get the slides up. Do I need to restart?
Exit, then restart.
Let's see. Let me escape.
Okay, and then go back to the slideshow.
Let's see here. Yeah, we good. Okay. So I'll give you the rationale. This was probably the hardest talk I've ever given, to actually give this talk. So, but it was a good exercise, and Uri's always good for stretching me intellectually. I think he made a good case that colonoscopy and FIT are both effective for screening, and the randomized. We're waiting for the randomized trials, and I think for all the reasons Uri mentioned, I think we're going to see that they look very similar. Based on the one-time application, however, colonoscopy does detect more advanced adenomas than FIT. More advanced neoplasia, but mostly due to advanced adenomas. The RCTs are ongoing, but based on modeling studies, colonoscopy does appear to be the winner, slightly more effective. And it's interesting how this has changed over time. If you follow the modeling studies that have supported the U.S. Preventive Services Task Force, for example, 2008, they looked almost identically equivalent, and now with the most recent modeling study, there does seem to be a little bit of a gap there. It may be recognizing the importance of smaller adenomas that affect those models, but it's kind of an interesting thing. But the main reason why I would say, be cautious about recommending that we go there is for FIT to be effective for CRC screening, infrastructure is necessary for sustained adherence and also colonoscopy follow-up of positive tests. And so we need to make sure we have those in place. And I will just throw a provocative statement out to our private GI colleagues in the audience that the screening infrastructure is complex and beyond the scope of most GI practices. And I think you could do this if we had a healthcare system where the specialists and the primary care doctors could work together to make sure this happened. So this is a recent meta-analysis that basically showed that for either any adenoma or advanced adenomas, colonoscopy does a better job. Now, most of these studies, I will say, I think all of them, were one-time application of FIT versus one-time application of colonoscopy. Most of the advanced adenomas are never going to become cancer. 80% of them will not become cancer or more. But, and you also, when you do a FIT program, if you do it right, then you have multiple chances to detect those advanced adenomas, hopefully before they become cancer. But some will still break through and become cancer before they are detected. This is just bringing back the modeling studies, and I'll just draw your attention to a couple of places on here. If you look at the life years gained, colonoscopy every 10 years on average was 310 life years gained versus 292 for FIT annually. So these are, and it's all, these models are all built on assumptions, and so, to the extent that the modeling is an accurate representation of reality, I think, this may be real. To the strength of the SysNet modeling, and I think Uri's got models also that may have shown something similar, but the strength of this is that it's several different models, so each one had their own assumptions, their own sort of mathematical calculations, so that kind of strengthens that potential gap. But this also assumes 100% adherence with screening, and for all the reasons that Uri told us, some people are just going to opt to do FIT, and in that case, FIT is obviously the best test for them. This is Uri's model, and it looks like colonoscopy is slightly ahead than FIT in terms of life years, or this is QALY's, cost per quality adjusted life year. This was that reference was more in comparison to fecal DNA testing, and clearly the cost of the fecal DNA test is sort of out of proportion to the potential benefits. And in fact, if you did the fecal DNA test every 3 years, the way it's recommended, versus FIT on an annual basis, FIT does come out a little bit ahead. But one of the reasons why the USPSTF then included a fecal DNA 1 year option was because they are forbidden by congressional mandate to include cost in any of their models. So if you leave cost out of it, then you might do the fecal DNA test annually. Now this is a follow-up study of a study that was done by John Inadomi back when he was at San Francisco General. I didn't show the data from that study, but essentially what he showed is in a federally qualified health center, if you gave people a choice of colonoscopy versus FIT, or you only offered them FIT, or you only offered them colonoscopy, either of the two arms that included a FIT option got much better participation in screening than the arm where you only offered colonoscopy. But what happens over time, and they followed, Peter Liang did a follow-up study where they followed people over 3 years, the benefit of FIT kind of wanes a little bit over time because they didn't have the infrastructure in place to ensure continued adherence with FIT over multiple years. So my bottom line argument is don't try this at home unless you're prepared to really do the right thing. And this is Kevin Selby was a research fellow with us at Kaiser Division of Research, and he's now back in Switzerland, kind of leading healthcare screening, colon cancer screening for his municipality in Switzerland. But he really helped us kind of break down all the components of our FIT program, and it's a lot. And we have the advantage. We have a financing advantage. We're all salaried. It's all prepaid healthcare. We're not trying to submit claims for each one of the services that we're delivering. And so each one of those kind of helps us make sure people adhere with FIT and also make sure they get a follow-up colonoscopy. We have our gastroenterology departments in many ways are actually tracking who's got a positive FIT in our electronic health system, and then doing the outreach to make sure those people are getting their follow-up colonoscopy. And we can get 85% plus of our FIT positive patients in for colonoscopy. We have an advantage of a majority commercially insured or recent retarees in Medicare, and so we have people with means who are able to, for the most part, come in and get their colonoscopy. Still, there's a solid 25% of people who, even when we tell them they should have a colonoscopy, are looking for any reason to explain that positive FIT other than colon cancer, hemorrhoids, or I took an aspirin, the day before, or whatever. So at that point, then we have to leverage primary care, the people that they know, to get them to come in to get their screening or get their follow-up. And there's a lot of components. I won't go into the details here. I'd be happy to talk to people during the break if they're interested. But it's complicated is sort of the bottom line for that. And so we'll stop there, and then before we go into the next topic.
All righty. Well, that was a fabulous coin flip. I can't possibly express how happy I am for both of those that you guys were arguing against each other. This is being taped, right? I have this. I have TR on record promoting colonoscopy over his career, life's work. That was beautiful.
But then telling you how you can really fit really well at Kaiser.
We can do it, but don't try it at home.
We'll take a couple of questions now before we move on to a third. And there were a couple, you were really talking about FIT versus colonoscopy, and that was the appropriate discussion. But there are a bunch of questions about Cologuard, about blood tests, Freenome, and the other sort of upcoming. Either of you want to comment on their role in that algorithm you're promoting?
Yeah, so interesting observation on Cologuard. So it's a good test, no question about it. It's costly. The question is the cost justified? As you may know, they have a function, a navigation function, to try to get people to do it. So some of what you're paying for is that. In our model, that's overpriced. So it really comes down to an economic argument. I don't think annual makes sense. I think the test can be done less often than that. The 3-year interval was plucked out of air. Talk about made up. It actually turned out that when we formally looked at this with the threshold of willingness to pay that's accepted, 3 years, we came out with 3 years. So that was a coincidence. So I think Cologuard's a good test. Cost is an issue. It's interesting, this thing about we all argue against ourselves. There's a meta-analysis by Tom Imperiali where he's comparing FIT and Cologuard. And if you lower the threshold of FIT, it looks exactly like Cologuard. I mean, identical in terms of sensitivity and specificity. So is there an advantage over just FIT at a different threshold? Maybe not. So that's an interesting question. So those are the stool tests. Blood tests, we'll see, but I've been surprised. I was kind of a skeptic. Are you really going to be that good at cancer? It seems promising. And they even seem to have decent detection for advanced adenomas, potentially. So I think we're going to see a new world for non-invasive testing.
Yeah, there's I think 4 blood tests that are currently either in development or actively in trials. And Cologuard also has a trial that's ongoing right now evaluating a new iteration of that test that has better specificity, they think. So I think the kind of drumbeat towards this kind of testing is going to be kind of relentless. And I think there's kind of no turning back with that. I think that's coming.
Microphone.
If all roads lead to colonoscopy, in other words, a positive FIT leads to a colonoscopy, which leads to removal of hopefully precancerous polyps. And the goal is not really to find a cancer, in my mind. The goal is to prevent cancer from happening. If you were to decrease the specificity or just make more positive fits, you would get more colonoscopies and it would actually function as a better test. So is it even really fair to compare these two models? Because a lot of times, most of the time when you have a positive fit, you're not finding cancer. So isn't FIT just another way to get people to get a colonoscopy, to take out a polyp, to decrease the risk of cancer?
It's a way to get people to get a colonoscopy, but it's also a way to make colonoscopy much more effective. You're finding, instead of doing a screening colonoscopy on a 50-year-old or 48-year-old woman who's got a relatively low risk, you're going to have a much higher prevalence of large lesions that are going to be the ones more likely to benefit. So I think you make colonoscopy more cost-effective by doing it. I think, as
Lesions don't bleed unless they're cancer. Most polyps aren't going to bleed. Most polyps don't bleed. So how do you explain a positive fit if a polyp doesn't bleed?
because I've seen some very large polyps that are almost, it's almost clearly bleeding, and that's why it's positive.
Most polyps don't bleed.
And most polyps don't become cancer. So that's the other side of it. But you're right. You're going to miss some polyps by doing FIT. You do it multiple times, obviously, and I think we're going to be seeing new technologies with new molecular signatures that are going to be more indicative of lesions that are going to be more likely to be problematic, and those are the ones we want to remove.
Fola?
Can you just comment briefly on the multiple different types of fit tests? So we're talking about fit as though there's one fit and all have the same quality. Is there any effort to unify utilization of fit to make sure that we're all using the right fit test or high quality fit test?
TR, why don't you take that?
I'll take that one. I think, yeah, I mean, we live in a capitalist society, so it's been hard to kind of really rein in the marketplace for all the different fit tests, but you're absolutely right. And I think the fits that are the one that we're using and that one has the best evidence behind it, in the US you buy it from Polymedco, that's the one that, with automated reading, you get a lot more accurate results. If you use the more, and that you can also get a quantitative result out of there, which provides a potential option to adjust the cutoff, as Uri was alluding to, so that you have a higher sensitivity by allowing lower levels of hemoglobin to stimulate a positive test. I think there's a lot of tests that kind of got approved by the FDA based on some analyte sensitivity. Could they detect blood if it was spiked into a fecal sample? And I think the way those perform, how reproducible the readings are, I think is really potentially problematic. So I think it's worth it if you're working in a system or we have a lab that's doing your fit screening to make sure you know what tests they're doing and trying to really encourage your system to use the best fits.
Two quick questions from here, and then we'll, all right, go ahead. We're going to move on, though. We have a lot more to do.
So a positive fit or a positive Cologuard will yield to a diagnostic colonoscopy that will apply to the patient deductible. So that's actually decreasing participation in the fit and Cologuard and probably the whole participation. I think we need some work on the Hill so that a diagnostic colonoscopy becomes screening after a positive fit.
Yeah, I agree 100% with that comment.
And your societies are working on that. That's issue one top three issue that we're all kind of working about. Quick one, what about fit after a history of polyps or cancer or asymptomatic patient with negative colon? When do you resume fit? So they're both fit questions, but so is there a role for fit after in surveillance, not in screening? And is there a role, when do you resume a fit after a negative colon?
Okay. So I think there is a role for fit in surveillance. We don't have any data yet. I've been working with Audrey Calderwood on designing a randomized trial for older people in particular. As people age, the risk of complications from colonoscopy go up, whether it's from the prep or from the actual procedure. And the potential value, particularly for people with low-risk adenomas, of doing surveillance is, may not be as strong, particularly than for people with larger adenomas. So I think there's definitely a role for non-invasive testing there. I think we need more data. And so right now, if you were doing it, you might be kind of outside of what would be considered standard of care. But I think it's going to hold up when we start doing studies on that.
And resumption of fit? Resumption of fit is the other question.
So I agree with what TR said. It needs to be explored. The Taiwan group has looked at this, and it makes sense for some subgroups. Resumption, I would go by the current guidelines. Again, there's nothing magical about the 10-year, but if you think that 10 years is an appropriate level of protection, you happen to have a colo, then you go out for 10 years, and if you want to screen with fit, I would resume it in 10 years.
Good. All right, let's move on. We have I'm going to call it a tie so far. I'm not going to say who won. There's no winner here. We're all winners here, but we're going to call it a tie. This is the third and final round. Gentlemen, have at it.
Yeah. Neil, you're making me think of when we used to coach that T-ball girls softball team. Yeah, there were no winners then. We were all winners then.
Do you have our participation awards ready?
Yes.
And it was like, I think the coaches were pitching, and Neil would sit on the sidelines heckling me while I was pitching to our daughters. So we'll go ahead with the rationale for the the question that we're really dealing with now is, should physician-level adenoma detection rates, ADR, should they be publicly reported? And I think this is controversial for sure. There's probably a lot of reasons, but I'll give you a kind of the pro argument for these and sort of the rationale. So I think I don't need to tell this audience that there's evidence that strongly supports the association between ADR and cancer outcomes, particularly incidence and mortality. And the other thing to say is that performance is not fixed. People can improve, and we have evidence for that. People may need incentives to improve potentially, and I think the other thing is that patients are asking. I know when I spoke to a physician who was working for a biotech company, and his wife needed a colonoscopy. She didn't have Kaiser insurance, and the first thing he said was, well, can you tell me what the ADR is of the gastroenterologist you're going to refer me to? And obviously I couldn't. We know that feedback has been shown to improve performance as well. And public reporting has been done. There's examples of this in the literature, so it's not a completely off-the-wall idea. And certainly it's been done in other conditions, whether it's heart surgery or other things that people are well aware of. And this public reporting example was from 10 years ago. So first I'll kind of remind everyone about the data. Doug Corley did a kind of a massive effort over examining colonoscopies over 10 years at Kaiser Permanente. Published this in 2014. And you clearly see, based on, he divided people up into quintiles. Again, we had the 5 fingers, so it was easy to kind of sort the group into the lowest fifth and then the upper fifth in terms of adenoma detection rate. And there was a clear difference in cancer incidence after colonoscopy among the low performers compared to the higher performers. In fact, the increment is very similar, particularly when you start looking at mortality. It's very similar increment between not doing any screening versus doing screening. So there's with the low performers versus the high performers. And again, this is old data, and there's been a lot of work done in our system to improve ADR and also elsewhere. Michael Kaminsky has definitely shown that in Poland, by increasing ADR, we've seen a decrease. He saw a decrease in cancer and CRC incidence over time as the average ADR improved in his population, and definitely clear that in a number of studies where feedback has been provided, this is a meta-analysis of provision of feedback to gastroenterologists about their ADR, and over time, the odds ratio summary odds ratio clearly favors that feedback can lead to improved performance. And this is an example from Illinois. A private group in Peoria was mandated by one of the employers in town to actually report the ADR of each of the, I think there was 11 gastroenterologists in this practice, and the employer said, if we're going to pay you to do colonoscopy on our employees, you need to publicly report. The way they set it up was actually self-reporting. Each gastroenterologist was responsible for tracking their own ADR, so I don't know how much gaming was going on in this kind of setting, but clearly over time, being told to report your ADR or essentially not be able to get paid to do colonoscopy. They did the reporting, and overall the group on average had higher detection of polyps, higher adenoma detection rate, and also some increase in the advanced adenoma detection rate, which is probably what most of us would care about. And at the provider level, we definitely saw, they definitely saw that there was, most providers increased over time as a result of the public reporting. So, I mean, it's a big stick, and I think, we have to make a decision on our willingness either as a specialty or as a group. I know that Neil's group, they report the average ADR for their practice, although the website's been a little hinky. Sometimes I check it and I can't get through, but I think they're trying to do the right thing. And I think they see that as a marketing advantage. And clearly, most big groups are looking for ways to demonstrate quality. And so I think being able to demonstrate your quality, I think, is really important. And I don't want to leave any of the potential authors in the room out of it. This is a construct presented by Fola and Asma Shakit, talking about how we can improve quality, how we can do quality improvement for colonoscopy. And it's a multi-component process. Certainly report cards and feedback are a big part of it. Definitely educational interventions. I know when we started on our journey of improving ADR at KP, it was clear that, first of all, our pathologists were also calling a lot of sessile serrated adenomas, hyperplastic polyps. And it was amazing the impact of just a 1-hour dinner meeting with an expert pathologist kind of changed practice almost overnight, just kind of raising people's awareness. It was a relatively simple intervention, but made a big difference. And obviously people can be taught about technique, and there's technology that's going to improve ADR. It's already in the marketplace, and more competitors are coming. So I think it's a reasonable, totally reasonable thing to expect that at some point, I think either payers are going to demand it, our patients are going to be asking about it, and I think all of us recognize the value, the importance of the ADR. So hand it off to Uri at that point.
Okay, thanks, TR. So MD level ADR should be publicly reported? No. Why not? Well, it's not as though this is going to fix things overnight. Within a given group, MD level disclosure alone may not move any needles. These data are admittedly a little old, but you can see various attempts in this group in Minnesota to improve ADR over time. Each line is an individual doctor, completely flat. And what did they do? Well, first a retreat in the green arrows. The ADRs were blinded. Then the MDs got their own individual ADRs. Then you can see letters, individual discussions, nothing. And the red ones here is ADR to the group, unblinded. You would think that here, TR sitting next to me, he's doing better than I am. Boy, I got to improve. Didn't move it. So this is even within the doctor group. Didn't do anything. Number 2, improvement is possible without open disclosure. And for now, discretion is probably best. So TR alluded to technique. There are actionable things you can improve, but I think it needs to be in an environment where people feel safe. Not that you're being scrutinized by the public every moment. So it would be counterproductive potentially to put people under this type of pressure. And what you see here is that on the left, withdrawal time, which is what started all of this, right? Longer withdrawal time, higher detection rate. There was no difference in withdrawal time between the highest and the lower detector, but there was a difference in technique. They videotaped how well do you look behind folds, how well do you wash. So people can learn, can improve, and it's not just about time. TR showed you his and Doug and others' data from Kaiser on the quintiles. This is the Kaminsky curve of their improvement study. Their initial study had a similar curve, but if you look at the x-axis here, these are not the quintiles of performance. They're what happened in terms of your improvement. So all the way to the right are the people in the best quintile. They stay in the quintile. They've got the lowest risk of cancer for their patients. But the next to the last one is people who improve from the lower quintiles to the best one. And before that, from quintiles 1 and 3 to 4. So if you improve, your patient's outcomes are better. Now, what I found fascinating is I went back a couple of years before this to the description of their program. And look at what they said about what they do. They give information to interested colonoscopists by email. So it's not to everyone. It's the ones who are interested in improving, and they give them league tables. Here is where you are compared to others. There's no public disclosure here. It's self-driven. It's people wanting to improve. So they achieve this without posting on the website, Dr. X is this, Dr. Y is that. I think we're not ready to handle MD-level disclosure to patients. There are many unknowns. First of all, what's the precision of your ADR estimate? It's a function of your colonoscopy number. It changes over time. You have the problem of updating the data. Can you escape your past? It's kind of like free throws. If you miss the first X number, how do you get your percentage up? And your number a couple of years ago, you really want to improve. That's the one that's stuck in the website. You live with your reputation as a low detector. It can be a mess. And what difference in ADR is meaningful? I think we would all agree that bringing low performers to a higher performing level is probably going to make a difference. If you're already a high performer, then can you improve? And do the tiny adenomas really matter? Or is this a proxy for detecting the more advanced lesions and completely resecting the more advanced lesions? It gets complicated. So we recently looked at this. These are all of our endoscopists in the Stanford health system. You can see on the left side is the measure of ADR, and the ranking here is by the middle panel, which is what we call the ADR ESS, or ADR extended to all screening and surveillance. So this was not just screening colonoscopies, it was screening first time, screening not first time, surveillance post-polypectomy, and also the general family history patients. So look at the confidence intervals. As you get more and more colonoscopies per doctor, the confidence intervals narrow. The overall ranking switches a little bit between the address score and then just the pure ADR. And the point is here that for some of our people, the confidence intervals are really, really wide. So what are we going to put in the website? I mean, do people understand confidence intervals? There are a lot of unknowns. And variability over time. The top panel on the left side is ADR. On the right is the higher N measure, the extended ADR. The top two are if you audit by every 6 months. The bottom one is if you order by quarter. So if you put data by quarter at the bottom, it looks like a mess. I mean, people are all over the place. At the top, ADR still bounces around a lot. The expanded ADR, it's more stable by semester. The outliers are people with low volume. So what are you going to disclose? It's very, very difficult. Now, am I arguing against myself? Here's my penance for showing the TR slide. I had to be a good sport. Why am I arguing against myself? Well, because we publicly disclosed. I just didn't tell you who's Nielsen sitting in the back, who's Rob, who's me. You don't know that, but this is Stanford. So are we going to get these patients, the guy in green? I only want the top guy. But then you have somebody else who says, no, look at the top guy or gal. They have a wide confidence interval. I want the top ones with a narrow confidence intervals. And then somebody's going to say, give me the top half, I don't want the bottom half. You know, I don't know if these are people who study health services with FOLA, but they exist. And so what are we going to do when people show up and say, who's who? We're not ready to handle this. What are patients going to demand? Are we shooting ourselves in the foot? If you're the patient, I think you have the right to know. I do agree with program level quality metrics. So we've put this out there. I don't know when I'm going to update the number, but that's our latest numbers here for Stanford. We're proud of this at the program level. Programs have to strive for all MDs to perform well, but how far to go? And this is from Roland Valori. Endoscopy services should have systems in place to monitor ADR and critically to feedback the results on a regular basis. There should be provision to motivate and support those colonoscopists who need to improve their detection rates. I think nobody disagrees with this, but I'm going to leave you with this last statement. And this is from Roland Valori. And importantly, to stop those who refuse to improve or are unable to do so from performing colonoscopy. Wow. So what are we going to do? So disclosure at the MD level, no. Internal disclosure may not move needles. Improvement is possible without public disclosure, and I think for now, discretion is best. We're not ready to handle the consequences. I think program-level data should be disclosed instead, and then we should work internally in our own shops to make sure that at the program level, we get all of our MDs to perform.
Thank you both. That was fabulous.
Yeah, that's good.
I will publicly go first and say, so I'm in between you, and we report at a program level, in essence, a practice level. We don't report individuals, and we have outliers, and we work on them, and we intervene in various ways, but we've come to a point in our practice where you can look up what my practice does, but you can't yet look up what I do. That's our answer to that. Questions? Anything? I'm looking here. These are not about this so much. ADR increased by longer intervals, favor MDs, less aggressive surveillance, should number of polyps per colonoscopy. Yeah, so could you change intervals based on your provider's ADR? Should we have individualized follow-up intervals? It's not a crazy thought.
Interesting, Samir Gupta just presented something at DDW using VA data on surveillance, and essentially he saw that the biggest predictor of finding a lesion at the surveillance colonoscopy was the ADR, or one of the big predictors was the ADR of the gastroenterologist who did the first. So you might actually have a paradoxical thing where if you're a low detector, you would be justified in doing colonoscopy more often and potentially have a higher income. So I don't know, that's kind of scary. So I don't know how we handle that. I don't know how we handle that as a risk factor for subsequent neoplasia, but it definitely is a big driver.
Yeah, I agree. There's no question that if you just analyze the data, it's a huge predictor. And I think it's the Polish program where they started to look at this. And if you took high-risk adenoma patients with high detectors, their subsequent cancer risk was comparable or maybe even lower than low-risk adenoma patients, people who are labeled as low-risk adenoma, but low detectors, because maybe they missed something. So it's a huge variable, but there's this perverse thing where you're absolutely right. You know, what are you going to do? You pay for bad performance with repeat colonoscopies? I don't know how we get out of that.
Yeah.
I think you kind of answered my question. Again, the question was that patient population makes a difference in adenoma detection. Maybe it's me, but my VA patients, I think I'm finding more adenomas than like my other patients that I get. So even if they come for surveillance, so I don't know if has anybody looked into it.
Yeah, Doug Corley did some analysis at Kaiser looking at risk factors, but it was within sort of the Kaiser population for sure. But he didn't see a big difference in terms of case mix, in terms of the polyps. But I would agree. Anyone who's worked at a VA knows that you see a lot. You see a lot more polyps. Definitely high DR. Yeah.
Yeah, I think in terms of starkly different populations, that's true. You know, the address score that I showed you where we threw everything together, we did a fancy one where we corrected with how many surveillance did you have and so on. This wasn't a patient characteristics, but by indication. That made no difference. So I think within a group, large enough period, it washes out. Between populations, where the populations are different, yes, there could be a difference, for sure. Yeah, so Fuller says males, tobacco, obesity. And some of the risk scores actually find those as the factors. So if you really have just those patients, yeah, it's going to be higher.
I got a question from the floor, so not from the floor, from the virtual floor. Dr. Kaura asks, ERCPs used to be sort of diagnostic and therapeutic, and now we've gone to a role of essentially therapeutic ERCPs. Do you see a parallel metaphor where we're going to go to a role of essentially non-invasive screening and only sort of therapeutic colonoscopy, so to speak?
You know, I think I tried to touch on that a little bit. I think we're moving in that direction, but I think colonoscopy is different from ERCP in that there will be room for some screening colonoscopy. And there are all kinds of issues here, right? People who don't want to have repeated testing. FIT's not a test, it's a program. And so I can see a scenario where if you get a high-quality colonoscopy and we get more confident in long intervals, maybe you just need 2 in a lifetime. Some people are arguing for 1 in a lifetime. And some people might choose that. And if payers say, I'm willing to do that instead of the whole thing, you know, not everyone can build out a program like TR showed us, then there is still room for screening colonoscopy in certain settings. So I don't think it's going to go away completely, but that's a good analogy towards more of the second step test, and you get into the whole thing by a non-invasive test. I think we'll see more of that.
I think as we start thinking about blood tests that are built on AI platforms and molecular screening, I don't think we'll know how much the companies are going to be able to charge for those tests. But I mean, maybe they'll be less. Maybe they'll be a little more affordable or cost-effective than Cologuard. But I think it's, you know,
At some point, if they cost more than a colonoscopy,
right,
we're going to go to a colonoscopy.
That's right, absolutely.
All right, the last question I want to take from a guy whose ADR used to be on my website, but no longer is. We've scrubbed it because Tom is retired and doing other things than hanging out with me. Tom?
Yeah, it's intuitive, but has it actually been shown that if you take 2 populations, one is just random screening versus someone who comes in for a positive fit, what is the ADR enrichment of doing a colonoscopy for a positive fit versus just randomly taking an asymptomatic person?
Yeah, so the find rates are higher in fit populations, and they should be. Interestingly, you know, in our Stanford data, they're not that much higher, but the advanced adenoma rate is definitely higher, which is what you want to see. You know, so there are all these other potential quality metrics that are not yet standardized for all kinds of reasons. But yes, the fit rate, the find rate of adenomas in fit positives absolutely should be higher, and when it's been reported, it is higher. TR, do you want to comment?
Yeah, and the other thing is I think some people are looking at, as Uri was alluding to, alternative ADRs, whether you take all comers. It's much less complicated to just take all your colonoscopies and measure your ADR. I think that has some promise because it'll make it easier for everyone to report their ADR, but I think we don't have the standardization against interval cancers or cancer mortality that we have that based on the work of Doug and Michael Kaminsky and others in Europe on the direct association with ADR on screening colonoscopy and outcomes. But I think that may eventually come in as we get a better handle on what kind of case mix matters in terms of measuring your total ADR versus just your screening ADR.
You know, in our numbers, it was different enough that we did not throw it into the address score. That was different. It was higher.
All right, well, this has been an extraordinarily wonderful morning. I'm really, really pleased. We've had 4 exceptional speakers share a lot of cool stuff with us, so I thank all 4 of you. We built a 30-minute break in for you, but we're going to cut it to 20, so sorry about that, but this was too much fun to stop early. We are going to resume at 11 o'clock. You're going to have a fun second half of your morning. We're going to learn about EOE. We're going to learn about advanced endoscopy. We're going to learn about premalignant lesions of the upper GI tract, and we're going to have a case discussion on IBD and surgery that's going to be interactive as well. So it promises to be fun. When you're out there, visit the booths, visit our sponsors, visit our posters, enter your ticket for a chance to win $100 cash. All those fun things are out there. We will see you back here at 11 o'clock. Thanks, everybody. Thank you, guys.
That was a lot of fun.
That was good.
Yeah.